the anemia problem is if you have too many red cells, and that's referred to as polycythemia. And polycythemia, you can think about it, you see what this slide indicates is the relationship between serum erythropoietin and serum erythropoietin on the y-axis and on the x-axis hematocrit. And so as the hematocrit increases, the serum erythropoietin goes down because a low hematocrit is going to be a stimulus for the production of erythropoietin. So you can think about problems with polycythemia as being, think about it in terms of whether it's erythropoietin based or not. So let's talk about some of the different causes of polycythemia. Erythropoiesis, which again is too many erythrocytes. You can see that you can have patients that have a problem with polycythemia because they have a pathological amount of erythropoietin present. So, for example, patients that have renal cell carcinoma, erythropoietin is produced in the kidneys. So, if you have a cancer that is lost, control of erythropoietin production, which normally is going to be driven by the hematocrit, then it can overproduce erythropoietin. You can have patients that have appropriate increases in erythropoietin, so they're appropriate, but still they're going to result in an overproduction of red cells. So, for example, patients that have chronic pulmonary disease or right to left cardiac shunt, which is going to result, as you recall, it's going to result in systemic hypoxemia. That's going to be a stimulus to the production of erythropoietin. And so what you're going to get is a hematocrit that is over and above the hematocrit that you expect to see in normal people. And we'll talk about some of the important as we go on. An important one in this day and age because of the propensity of aging males to seek testosterone supplementation is that testosterone supplementation can cause response to drugs. So let's talk with. Okay, so this is going to be the diagnostic approach for the patient that has. Let's delay a discussion of this before we talk a little bit about some of the different causes. In the book they talk about one of the causes of polycythemia is a hyperproliferative state of the bone marrow, and an example that they give of that is polycythemia vera. Polycythemia vera is one of the myeloproliferative diseases, of which there are 4. Okay, so and 3 of them correlate with the different cell lines, and then there's a 4th one. So the hyperproliferative states include polycythemia vera, which we're going to talk about, CML, or chronic myelogenous leukemia, essential thrombocytosis, where the primary disturbance is in the platelet lines, and then myelofibrosis. So CML, which affects predominantly white cells, polycythemia vera, which affects predominantly red cells, essential thrombocytosis, which affects predominantly platelets, and then primary myelofibrosis. And the thing to be aware of is that, just as we said with aplastic anemia, it's a misnomer because the disturbance affected all of the cell lines. Same thing is true with polycythemia vera. The question is, which line is predominantly affected? Okay? Erythropoietin, the erythropoietin level is going to be low in these cases because the cell lines are basically because the malignancy, the abnormality is in the hematological cells, the hematological precursors. They're independent of erythropoietin. And so the red cell mass is going to go up, and that's going to suppress erythropoietin production by the kidney. If the kidney sense that the hematocrit is plenty high enough, it's going to shut off erythropoietin, as we saw in that first slide that I showed you. Okay, it'll turn off the production of erythropoietin. Yeah. Okay. Now another cause of polycythemia are those causes that are associated with elevated erythropoietin. We talked about some of those in the slides that I just showed you. Again, one of the tip-offs for these patients is that only the red blood cell line is going to be affected. Because if the problem is with the primary overproduction of erythropoietin, if that's the primary disturbance, then you would expect the problem would be limited to the red cell line. So you're not going to see any involvement with the white cell line, with the platelets, or anything else. Okay, so let's talk a little bit about the approach to the patient with polycythemia, diagnostic approach. And this is from Up to Date, and they're telling us we have patients with polycythemia, and they're telling us they're distinguishing between patients that have polycythemia vera-related features and patients don't. We're going to talk about some of the signs and symptoms of polycythemia, but for example, patients that have polycythemia vera, they have often complain of pruritus if they take a hot bath, and it's associated with splenomegaly. Okay, so and again, you may see some abnormalities in the other cell lines. So if you suspect that polycythemia vera, you're going to check an erythropoietin level. Okay, again, you would expect the erythropoietin level to be low because if the red cell mass is high, okay, and it's polycythemia vera, then the kidney production of erythropoietin is going to be suppressed. It's going to be turned off. So to get that result, the result you expect, then it's polycythemia vera. Okay. If it's elevated, then you have miscalculated and you're dealing with a case of secondary erythrocytosis. Okay. We talked about some of those secondary causes before. Here. Now, what if it's normal? Well, if it's normal, it shouldn't be normal. If it's normal, it suggests that it's kind of high. Okay, so it's higher than it should be for that hematocrit. So you have to work this up. You have to parse this out. The recommendation is to obtain a bone marrow. If the bone marrow is diagnostic for TB, you've made the diagnosis. If it's not, then you have to pursue other studies. Don't worry about this for now. Okay? If the polycythemia vera related features are absent, then you're going to proceed to check the erythropoietin. If it's elevated, again, that goes along with it being secondary erythrocytosis. So then you just need to figure out which disease entity is causing the secondary erythrocytosis, whether it's, for example, chronic pulmonary disease, some type of shunt, or one of these other abnormalities. And if it's low, again, it's going to suggest that maybe you're dealing with polycythemia vera, even though there were no polycythemia vera related features on the history or physical. And then intermediate, again, is going to be unexpected. And so again, you have to work it up further. Okay? In terms of the management, it depends on what's causing the polycythemia or erythrocytosis. If it's polycythemia vera, it's a myeloproliferative disorder, and so these patients are often treated with myelosuppressive agents, including hydroxyurea. They're given aspirin for lack of a better term, send the blood. And sometimes they can be managed with phlebotomy. Hydroxyurea, though, is commonly used in the management of these patients. An interesting thing about hydroxyurea, which I didn't know until a few months ago, I had a patient with polycythemia vera who presented to the wound center with an ulcer on the medial ankle, on the medial malleolus. It wouldn't go away. So you go through the differential diagnosis. That's in the territory that venous insufficiency commonly arises. It didn't look like a venous insufficiency ulcer, and it kind of looked like an arterial ulcer, but the arterial studies were good to figure out why wouldn't this ulcer go away. Polycythemia vera, I'm thinking, okay, maybe there's something about the disease associated with these ulcers. And he's on hydroxyurea, and I've never heard anything about this, but I just, you do a medline search. Turns out that hydroxyurea has been reported to cause the ulcers of the medial malleolus that don't go away until you stop the hydroxyurea. When you stop the hydroxyurea, a few weeks later the ulcer goes away. So it's just it was a fascinating thing. I've never seen anything like that before, but just to illustrate that sometimes you gotta look stuff up. All right. All right. Anything about the polycythemia? Otherwise, what we'll do is we'll turn to the white cells. Okay. I think what we're going to do is try and finish heme today, and then we'll do rheumatology, and maybe I'll try and give you some guidance about what's important and what isn't important. So, we put up the test for that yesterday. All right. Let's talk about the white cells. And the first topic that so let's talk about the first topic that they bring up are the different forms of hypersensitivity. Have you studied the different forms of hypersensitivity in physiology? Okay. So I'm not going to belabor the point. What I will tell you is that if you want to go to So if you just Google higher edge raw hill animation hypersensitivity, it will give you it'll take you to a simplified animation that will explain each of the types of hypersensitivity in a relatively simple fashion.
Type 2 hypersensitivities involve interactions of antibodies and surface antigens of cells, followed by complement-assisted lysis of these cells. A typical example is mismatched blood transfusions. There are 4 different blood groups based on types of antigens on the surfaces of the red blood cells. People who are type A have A antigens, and those who are type B have B antigens on the surfaces of their red blood cells. Persons who are type AB have both A and B antigens, and those who are type O have neither A nor B antigens. The serum of people with type A blood contains antibodies against type B antigens, and the serum of people with type B blood contains antibodies against type A antigens. Type AB serum contains neither antibody, and O serum contains antibodies against both A and B antigens. If blood from a person who is type B is transfused into a person who is type A, antibodies present in the type A blood react with the surface antigens on the incoming red blood cells. This leads to complement fixation and lysis of these cells. If blood from a person who is type A is transfused into a person who is type B, antibodies present in the type B blood react with the surface antigens on the incoming red blood cells. This also leads to complement fixation and cell lysis. Persons who are type O lack A and B antigens on the surfaces of their red blood cells and are therefore universal donors. Persons with type AB blood lack antibodies against A or B antigens and are therefore universal recipients.
Okay, so and there's a little video for each of the different types of hypersensitivity: type 1, type 2, type 3, type 4. So take a look at that. It's helpful, and it may help clarify some of the material in figure 6.8 at the bottom of page 126. You see that what they do is they talk about the mechanism of each type of hypersensitivity, and then they give you examples of it. And the reason that they give you examples of it, I guess, in this chapter is again because of the relationship with the hematological reactions to blood transfusions, and also because of the role of the white cells in all of these processes. Okay? So, all right. So let's talk a little bit about. I want to highlight some of the material related to the different types of hypersensitivity reactions. To give you the example of type 2, and again, some of this might be useful in terms of the next topic that we take up, which is rheumatology. So, for example, if you look at type 2, they point out that type 2 hypersensitivity is an example of the incompatible blood transfusion that they just showed you, but also Goodpasture syndrome, which we're going to talk about when we talk about rheumatology, but also we talked about it when we talked about renal, right? And we talked about it when we talked about pulmonary. If you remember, it's the patients with the Goodpasture syndrome, they develop glomerulonephritis, but they also cause hemoptysis. Okay, so that's an example of type 2, and pernicious anemia. The process that results in pernicious anemia is also type 2 mediated. Okay, type 3, which is immune complex mediated. Examples of diseases that are caused by that include post-infectious glomerulonephritis, rheumatoid arthritis. We'll be talking about in the next chapter systemic lupus erythematosus, and polyarteritis nodosa. Remember we said polyarteritis nodosa is a close association between the development of that disease and certain activities like hepatitis B. Right? So that would explain why type 3 is important. Type 4 is the mechanism that underlies the reaction to tuberculin in the skin, so the PPG testing and rejection of transplanted organs. Okay, so let's talk a little bit about the first. So the first topic that they talk about is hypersensitivity, which again refers to exaggerated immune reactions. The second topic that they talk about, again, is the flip side of that, which is immunodeficiency. And immunodeficiency can be either primary or secondary. Okay? And immunodeficiency matters because it predisposes patients to the development of opportunistic infections. So let's talk about some of the approach to the patient with suspected immunodeficiency, some of the initial tests that you might send off if you're worried about a patient having immunodeficiency. So if you're worried about somebody having a problem with their B cells, issue with their B cells, you can check serum IgG, IgM, IgE levels. It's serum immunoglobulin levels, basically. If you're worried about somebody having a T cell defect, you can check for a delayed hypersensitivity skin reaction with Candida. So Candida is everywhere. So if you inject with Candida, the patient shouldn't develop a delayed hypersensitivity skin test with Candida. If they don't, then it's full allergy. Okay? If you're worried about a phagocytic cell defect, you can check neutrophil and monocyte counts. Again, that's only going to tell you about numbers. It's not going to tell you about function, but it will tell you about numbers. And then if you're worried about a complement deficiency, you check the C3, C4, and TH50. Okay, so the first, in terms of, let's talk about the white cells first. And the first abnormality that they talk about is basically neutropenia, a decreased number of white cells. And that can happen for lots of reasons. They give some examples in the book. Exposure to radiation, certain drugs can cause neutropenia, including cancer chemotherapy is notorious for doing that. Certain infections, involvement of the bone marrow. They mentioned something called DeGeorge syndrome at the top of page 127. They point out that if somebody has a problem with their bone marrow, it's unlikely to involve just one cell line. It's going to involve 4 cell lines, red cells, white cells, platelets, etc. And so if they have just a single cell line, it suggests something else. They talk about DeGeorge syndrome, and DeGeorge syndrome is a primary immunodeficiency. Patients with DeGeorge syndrome have unusual faces and low-set ears. They can have congenital heart abnormalities, including aortic arch abnormalities, and they're prone to recurrent infections. DeGeorge syndrome. Now the other possibility is, and by the way, a decreased number of white cells. The normal number of white cells is going to be indicated on the CBC that your normal range. If it falls below that, then you're dealing with neutropenia. And of course, the lower the number, the worse it is. And then a critical number, I guess around 500 neutrophils. Once it becomes lower than that, then patients are really critically neutropenic, and they're prone to the development of life-threatening infections. So most people have to be drummed on if they get an infection, because they can succumb rapidly to an infection if it's not treated. The whole topic, we don't get to take it up in this course, but the whole topic of febrile neutropenia is an interesting topic, serious topic. If somebody presents with fever and neutropenia, that's a medical emergency, and there's a certain procedure that you have to go through to make sure that you don't mess that up. So febrile neutropenia is an important topic that, again, we don't really talk about in this course, but we probably either have talked about it or will talk about it in clinical medicine surgery. Okay. The second thing that they talk about is the function of the white cells. Patients that have functional abnormalities of white cells, even if they have normal white cells, and that's indicated in figure 6.9 at the bottom of page 127. So patients can have, for example, problems with leukocytes, the ability of leukocytes to adhere to the endothelium of the vessel to be able to get through it and get to the sites of inflammation. They can have problems with phagocytosis and locomotion, as indicated in, again, figure 6.9. Shediac-Higashi disease is the example they give you of that. And then they can also have problems. They can do everything else right, but they have problems generating the intracellular toxins that actually kill the bacteria. They can have that problem for a couple of reasons, including chronic granulomatous disease and a deficiency in myeloperoxidase. So if they have problems with the intracellular machinery that generates the free oxygen radicals that kill the bacteria, then even if everything else is working, they're going to have an immunodeficiency. So again, for our purposes, just know what is wrong with the white cells in each of those diseases. So, for example, you should know that chronic granulomatous disease involves defects in intracellular destruction of pathogens, okay, as opposed to a problem with adhesion or locomotion of phagocytosis. Okay. Now, in terms of neutrophils, okay, so I see what they're doing here. Okay, so they were talking just generally about white cells, but mostly they were talking about neutrophils. They turn specifically to neutrophils here, and the first thing that they talk about is an increase in neutrophil count, and you can see that for lots of reasons. Obviously, it's a marker of infection, so when we get CDC, if the WBC count is elevated, we might surmise that the patient might have an infection. The other thing that we look for in patients with an infection on the CDC is the appearance of immature forms of white cells, so bad. Remember when you saw this picture of remember, this is a normal-looking white cell that has basically multiple lobules, three lobules, so it's segmented. Well, a band, it might just look like one thing without separate lobules, just one, without being segmented yet. Okay, so it's an immature form of a white cell, and so a bandemia, or an increase in the number of bands in the blood, is often a marker of infection. Other things that can cause increased neutrophils, they point out any kind of inflammatory disease doesn't of steroids. Right? Steroids cause an increase in the white count, by what's referred to as demargination. So, for example, if you look at figure 69 on page 127, you see that a certain fraction of the white cells hang out attached to the vascular endothelium. They're just stuck there, okay? So when you draw blood, you're not pulling from that pool. So they're stuck to the endothelium. They're not moving, okay? So when you give somebody steroids, they demarginate, they release their grip on the vascular endothelium. Now they're in the general population of white cells. So you can see an increase in the white cells in patients that are treated with steroids. So that's important because often patients that are on steroids are immunosuppressed, so oftentimes we're looking for infection. And so that kind of complicates the assessment of infection in the patients with steroids, right? They tend not to get fevers, right? It tends to mask inflammation that might produce other signs of infection. And it raises the white count, which is one of the things that we look for to see if the patient is infected. So the assessment of the patient who is on steroids, the assessment of that patient for infection is complicated. Okay? You have to take all that stuff into consideration. And of course, besides everything else that we talked about, people can have an elevation in the white cell count because of a malignancy. And they mentioned CML, which again, remember, is one of the myeloproliferative disorders. CML, myelofibrosis, essential thrombocytosis, and polycythemia vera. Okay? And of course, they can have acute myelogenous leukemia as well. So what? Yeah. Would be what? Neutrophils. Neutrophils go up. Actually, the lymphocytes go down. Neutrophils go up. Yeah, it's just the neutrophils. But that's the easiest way to think of it. By the way, CML, we said, is a myeloproliferative disorder. We told you the other ones that are associated with it. And the easiest way to think about the difference between CML and AML is where in the cascade, okay, so here's the white cell, right? The best way to think about CML and AML is that CML, here's the band, by the way, okay? CML is a problem, a proliferation of a cell that is closer to this end of the differentiation pathway. It's more normal. It's less dedifferentiated. Okay? AML is the proliferation of an early cell in that pathway. Okay? So it is more dedifferentiated. Okay? That's the difference between AML and CML, kind of physiologically. Okay? Okay, so let's talk. So now the next thing that they talk about is the next thing that they talk about is decreased neutrophils, either number or function. So these are we talked about some of the causes of neutrophilia. There, demargination, neutropenia. We talked about some of the causes of neutropenia. Okay. So let's talk about neutropenia, classification of neutropenia. So I think this is up to date. Mild neutropenia would be 1,000 to 1,500 neutrophils per microliter. Moderate would be 500 to 1,000. And severe is less than 500 neutrophils per microliter. Patients that have neutropenia are mainly at risk for bacterial infections. So, for example, Staph aureus, gram-negative rods, and also systemic fungal infection. Okay? So one of the things that you'll see when you read about the febrile neutropenic patients is that they quickly get admitted, they get cultured, everything gets cultured, they get evaluated to see if they can find the source of the infection, and then they get treated empirically for the organisms that are likely to cause it. So they get coverage for gram-negative and staph, and they treat, and then if they're not getting better, okay, one of the things that happens later on in the course is sometimes they will put you reevaluating them every day, but again, if you're still not finding anything, a lot of times what they'll do is they'll institute treatment for fungal infection. So you'll read about that in clinical medicine and surgery. Okay, lymphocytes. So the first thing that they talk about are causes of lymphocytosis, or an increased lymphocyte count. So you have this slide that depicts some of the causes here. Obviously, viral infections are going to be associated with the lymphocytosis. Just be aware that early on in the course of any infection, sometimes you will see an elevation of the neutrophils. But then, as time goes on, you'll see a shift to predominantly lymphocytes in the viral infection. You can see, so again, certain infections can produce lymphocytosis. You can have immunological abnormalities producing lymphocytosis. Metabolic disease, lymphatic disease. Why do you think Addison's disease might be associated with a higher number of lymphocytes than normal? Something I just told you a little while ago. So look at lymphopenia. You can have lymphopenia from AIDS. Right? Yeah, cortisol decrease in Addison's disease. And so you lose that the effect of cortisol tending to suppress the lymphocyte count, so the lymphocyte count comes to be elevated. Again, the lymphocytic analogs of AML and CML are ALL and CLL. And I don't know if we talk a little bit about those later on. But again, the way to think about those diseases, the same way, think about the lymphocyte. So the question is going to be, where in the cascade, in the differentiation from this cell to this cell, does the process go awry? Okay? And so CLL means that the process goes awry closer to this end of the differentiation pathway, and ALL means the process goes awry closer to that end. Okay? Okay. Decreased lymphocytes. Again, drug toxicity can do that. We talked about steroids. Chemotherapy can do it. Certain infections such as HIV. Besides problems with numbers, you can have normal numbers, but you can have problems with cell function. So if you're talking about B lymphocytes, you can have problems with antibody production. And some of the book references problems with antibody production And they list some genetic causes of that, including X-linked agammaglobulinemia and common variable immune deficiency. You should know that there are also acquired forms of antibody disorders of antibody production, and they would include, for example, patients that have multiple myeloma and patients that have CLL. The patients that have problems with antibody production are, again, at risk for pyogenic infections, bacterial infections. Yeah.
You said CLL can cause an increase in lymphocytes.
CLL causes an increase in lymphocytes, but it can cause a problem with antibody production. You can have a normal number of cells, they're just not working the right way. So let's talk about the qualitative problems with lymphocytes. And again, if you're going to talk about problems with the lymphocyte function, you have to divide them into two. We'll explain this and then we'll stop. You have to divide them into two categories, the T lymphocytes and the B lymphocytes. So with the T lymphocyte function, we're concerned with cell-mediated immunity. The problem is going to be one of cell-mediated immunity. And patients that have problems with T lymphocytes, either number or function, okay, are going to be prone to the development of opportunistic infections, including viruses, mycobacteria, fungi, and protozoa. Of course, HIV is the paradigmatic example of the patient that has a problem with cell-mediated immunity. But that, just HIV. And cell-mediated immunity, yes, they do. HIV patients are patients that have cell-mediated immunity for any reason. With B lymphocytes, again, the problem is going to be with antibody production. These patients have what are referred to as opsonic defects. So if you look at page 127, figure 6-9, you see that one of the ways that the body deals with bacteria, especially encapsulated bacteria, is to opsonize them. Okay. And patients that have opsonic defects, that have a problem with opsonization, include patients that have problems with antibody production, that can produce an opsonic defect. Patients that have a complement deficiency, that can produce an opsonic defect. And patients that have splenectomy, because they need the spleen to finish off these opsonized bacteria. So problems with antibody production, problems with complement production, or problems if the patient has had a splenectomy, those people are said to have opsonic defects. Any of those things make them defective opsonically. Patients that have opsonic defects are prone to the development of infection with encapsulated organisms. They are unable to, they cannot be phagocytized unless they're encapsulated. And so these organisms include pneumococcus, Haemophilus influenza, and meningococcus. For example, you can see patients that have sickle cell anemia. They develop, because of splenic infarct, recurrent splenic infarct during childhood, they basically auto-splenectomize themselves. They don't have a spleen at some point in time. The spleen is gone. And so they are essentially asplenic. And so they are prone to the development of infections with encapsulated organisms, overwhelming pneumococcal infections, things like that. So key thing to remember, patients that have problems with antibody production, patients that have problems with complement, okay, or patients that have had a splenectomy, they have an opsonic defect and they're prone to the development of infections with encapsulated organisms. Because again, they can't opsonize as is illustrated in figure 6.1 of page 127. All right, let's stop here, and we'll come back in 10 minutes.